Thank you for joining us this evening. This is our 9th COVID conversation, and we have amazing guests that we owe a lot of gratitude for serving on the Advisory Committee for Immunization Practices. Just a couple of housekeeping items first. All lines are automatically muted during the program. There is a question and answer box at the bottom of your screen. Please use that to ask a question. And we will be scrolling through those questions during the talk to be able to ask some of those questions. The webinar will be recorded and posted to the California Immunization Coalition website afterwards, as well as to YouTube. As I said earlier, all participants are in listen mode. Please go on to the next slide. This is put together by the California Immunization Coalition, which is a nonprofit public-private partnership dedicated to achieving and maintaining full immunization protection for all Californians to promote health and prevent serious illness, disability, and death. And co-sponsored by the American Academy of Pediatrics, the 3 local chapters here in California. The AAP California is committed to the attainment of optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults living in California. I am Pia Pannaraj. I am an infectious disease doctor at Children's Hospital Los Angeles, and my co-moderator is Dr. Eric Ball, who is a primary care pediatrician at the Children's Hospital Orange County Primary Care Network. So next I'll introduce our 2 speakers. First, Dr. Grace Lee. She is Associate Chief Medical Officer for Practice Innovation at Stanford Children's Health Center. And most importantly, she is the current chair of the U.S. Advisory Committee for Immunization Practices that voted just 2 days ago to approve the pediatric COVID vaccine ages 5 to 11. And I'd also like to introduce Dr. Oliver Brooks, who is the Chief Medical Officer and past Chief of Pediatric and Adolescent Medicine at Watts Healthcare Corporation in Los Angeles. He's also the Medical Director for LA Healthcare Plan. He was the former president of the California Immunization Coalition, and currently is also a voting member of the ACIP. So we thank both of you for being here today.
Our pleasure. My pleasure.
Before we started, I wanted to say on behalf of the California Immunization Coalition, the American Academy of Pediatrics, and all pediatricians and family practitioners, a sincere thank you to Dr. Lee and Dr. Brooks and all of your colleagues. Many of our patients' lives have been dramatically changed over the past few days, and I've had parents crying in my office after we gave their kids their first COVID vaccine. And I know you guys have worked tirelessly to make this happen, and these decisions have not been easy, and there's a lot of pushback. And we all wanted to say thank you for your time and dedication and for all the work that you guys are doing for kids. And with that, I'm going to turn this over to Dr. Brooks to give a quick introduction, and then we'll get on to our conversation.
All right, thank you. And thank you, Dr. Bell and Dr. Pannaraj. We're happy to be here to provide this information. So we're going to briefly roll through these slides because what we really want to do is have conversation. You know, that first slide had me listed first because I put these together. So any errors and problems in these slides are totally my own. Okay, so we do know that 2 days ago, it was unanimous vote to approve the Pfizer vaccine for children aged 5 to 11 years old. That was after the FDA was approved. Overview, if we immunize kids 5 and older, we help them from getting COVID, help them if they do get it from disease, hospitalization, death, long-term complications. They're less likely to have problems. They still are at risk. Next slide. 5 to 11, 2 doses, 3 weeks apart. We can talk about that they're fully vaccinated, considered such 2 weeks later, can give it concurrently with other vaccines. So 28 million children ages 5 to 11, 1.5 million cases of COVID-19 within this age group. And again, some of this data is a little old, but it's relevant enough. And there were 94 deaths, I believe is what it was. So it is relevant that we get this population vaccinated. Next. Okay, so the vaccine is safe and effective. There were 3,000 children 5 to 11 in the studies. And this is generally how vaccine studies are done in children. They get passed in a higher age, approved in higher age group. Then we work down with bridging, as it's called, immunobridging, to the younger children. The dose is 20 micrograms for the children 5 to 11, 1/3 the dose of 10 milligrams, 1/3 the dose of 30 milligrams for adults. Next. There were cases of myocarditis and pericarditis in the 12 to 25-year-old group, which was the comparison group for the studies. In the 5 to 11-year group, there were no cases of myocarditis or pericarditis. There was some information on VAERS, and this data is for the children 12 to 15, about 40 per million in males and a lot lower in females. Next slide. So this is just kind of a busy slide. Excuse me. It just talks about the dose being 1/3. Packaging is different. The buffer is different, and therefore the storage is different. I think that's the most important thing on this slide. It is stored at 2 to 6 degrees Celsius for 10 weeks, unlike the adult version. And once the vial is punctured, it lasts 6 hours. Next slide. So it can be given with other vaccines, and it should be. My point being, if someone is coming in, a child's coming in, they need other vaccines, go on and give it. Next slide. So equity is and has become a factor in the determination of ACIP's work for all vaccines, and that's only been in place for 2 years. So I think it's important to understand that we do safety, efficacy, and whether we do reviews for cost effectiveness, but equity is involved in every decision. So there is concern about equity. African Americans have a lower rate of getting vaccinated, a higher rate of hesitancy, and higher rate of complications. So we are concerned about that. Those that have limited access, social inequities, children with disabilities, special healthcare needs, living in congregate settings. All these are aspects of why that we take into account and was part of our decision making to say we do, by unanimous decision, recommend this vaccine. Next. And so there are issues, as we know, with hesitancy and confidence. See, 34% of parents said they would get it right away, 32% wait and see, 7% only if required, 24% definitely not. So we need confidence. And I like this at the bottom. Misinformation is information that is shared by people who do not intend to mislead others. They have false information, they're spreading it. Disinformation is purposeful spreading of wrong information. So a lot of what we actually hear is misinformation. People just don't believe it, but there are those out there that are they're purposely giving incorrect information. And that's why the vaccine confidence has waned some. Next. So this, I don't even want to go through the technical aspects of this, but there will be the way that you order the vaccine, when you get it, how you store it. Next slide. So in summary, something I didn't even mention, but school. So kids, they get vaccinated, they're less likely to be disruptions with school. Vaccinating children 5 to 11 is critical to preventing infection and possible severe disease, as well as reducing the spread, especially the widely circulating Delta variant. It's part of bringing it in. I don't know about bringing it in, but bringing it down to a smoldering ember. the pandemic. It'll help other people from getting COVID. It is helping to reduce the amount of non-in-person learning. So tele-school, we have more in person, which is good. And it can protect others who are at high risk of COVID. So with that, that's just laying a little groundwork. Thank you. That's it. So just laying a little groundwork for any discussion that we can now have, Dr. Ball and Dr. Pannaraj.
Thanks, Dr. Brooks. That was a great way to set the table. So I wanted to start by talking to you guys both about the ACIP, so the U.S. Advisory Committee on Immunization Practices. So this is a committee of the CDC that before this pandemic happened, only pediatric infectious disease doctors knew what it was or what they did. And now this is like must-see TV. I mean, I listened to a good part of the meeting on Tuesday. Many of my friends live blogged it. It's pretty crazy. So my first question to you guys is, what is that like? What is it like to have all of this attention put on immunizations, ACIP? How have you guys been dealing with that?
Grace, since you're the chair, first.
Well, I have been on ACIP since 2016 as a member and became chair this year. I should actually also, before I start, just say thank you so much for inviting us. I mean, it really is our pleasure to serve on the committee. It is our honor to, be here today and to make sure that we can help take the recommendations that come out of ACIP and make sure we can really get it to the front line in the best way we know how, recognizing that the data are continually evolving. And so we want to make sure we can answer any questions that we can today for you. So ACIP, it's been interesting. I would say that, well, hopefully it wasn't just pediatric ID docs, but also adult ID docs and our OB friends who also are paying attention, and I would say geriatricians as well, to ACIP. But yes, it's been not something that typically we are thinking about during our scientific conversations during the meeting. I think what's been different for me personally is that we try and maintain that same level of inquiry and discussion and conversation that we need to be able to make a recommendation. But we're just also very cognizant that many people are listening, and it's also an opportunity to communicate more publicly and try and translate some of our questions into what this really means for patients, families, and providers. And so it does add an extra layer of just sort of thought, I guess, in terms of our deliberations. But I, hope that you're seeing that we are still true to the process of ACIP and what we intend to do, which is to make sure that we are reflecting the diverse viewpoints of the committee. But I'm curious, Dr. Brooks, what you think about your experience.
So I've been on for 3.5-4 months. And when I got asked to be on, I was really honored. And I have to say that I can't imagine how Dr. Lee is doing this as chair, because it is incredibly difficult to chair the meetings. It's difficult for me just being on them. So what I would say is this: it has been intense. It's been probably one of the most intense periods of my life ever. Because what you said, Dr. Bell, we're on the front page every day. Vaccines are on the front page. So, and I take it very seriously, obviously. We got I had never received as many emails as I had about when we were making the decision for the pediatric age group, well, the 5-11 year-old age group. So a lot of information coming in, mostly against the vaccine, I must say, because there's a strong minority of those that are against the vaccine. But we understand that. And so I think that I won't say it's healthy, but I mean, the fact that it's being looked at is good. And so what Dr. Lee said was part of how we handled the meeting. I mean, we would make points to kind of address some of the dis or misinformation, you make the call, that was coming out. I thought that the pneumococcal one was probably the most difficult in terms of that decision, in terms of how the information was presented. I too sit on the COVID-19 vaccine work group, so I've heard almost all the information at least once before it comes to the whole of the ACIP. But I will just say that it is a true experience and an honor to be involved in this committee.
Can you tell us a little bit about the process? When do you see the data, first see the data, and what is your process in reviewing it before coming to make a decision on the day of the meeting?
Sure. So I'll just jump in and say that I did not realize until I joined ACIP how much work goes on in between those 3 meetings. It's normally 3 meetings a year. I think we're up to like 20 or something right now, but normally it's 3 meetings a year. And you, when you join ACIP, you have this like incredible respect for how much the work groups do to be able to make sure that they're reviewing the data in depth and detail, and bringing to the full ACIP meeting, the open public meeting, all of the key and salient points that are relevant for decision making. But certainly all of that is reviewed in detail prior to, and a great example that Dr. Brooks mentioned is the COVID-19 vaccines work group. Most of our work groups, I would say, typically meet on a monthly cadence, but this work group in particular, both the COVID vaccines work group and the COVID-19 vaccine safety technical work group, have essentially been meeting on a weekly cadence since the pandemic, and it hasn't let up. But it's it's our opportunity to make sure that we really understand and ask the questions that we need to, that we think the committee needs to hear. Only a subset of individuals are on these work groups, and it's really important that, and all of us serve on different work groups, but the full committee only hears that data in open meeting. So all of that discussion by the committee is deliberated in public, and that is very intentional. We are actually not allowed to talk as a full committee outside the open meeting, only through the work groups, and only a subset of members serve on each work group.
And let me add that the data and the information that is presented at the work group level is dissected. I mean, down to what's in the footnotes. Questions are asked that are very detailed, very deep. Rob Schechter, our immunization leader here in California, he's on there, and he asks very challenging questions. Mm-hmm. It is not a rubber stamp committee. I mean, the decision, let's say, was 15-0, but I'm telling you, at the work group level, there's a lot of discussion, a lot of skepticism, healthy skepticism. Mm-hmm. What I mean, prove to me that this data that you're showing me is accurate, in that type of thing. So I think that some of that may be missed at the whole meeting, because we just don't always get that deep into the detail, but it is done at the work group level.
So I think that's a good lead into the next discussion that we want to have. So I think we're going to kind of delve down deeper into the individual aspects of the vaccination for children. But if you guys could each just in a general way explain how you came to your decision that the benefits of the vaccination outweighed any potential risks.
Dr.
Oh man, I wish I brought. Actually, that's funny you should ask that, Dr. But because I ended up having 7 or 8 lines at the very. I take notes because it's so dense that I actually literally I had 4 pages of notes from that meeting. But at the very end, I had written things, and I can't remember all of them, but I know one of them was that I'm worried about equity, because without this, there are going to be children that are out there, they're going to be at home more, and they may be the ones that have less access to other services that they may need in the future. That I do believe, even though it was kind of disputed, that there is a benefit to having a higher level in the community. Key, vaccine is safe and effective. That it only takes 10 doses to prevent 1 case. That like right there was almost all I needed to hear, other than the fact that it was safe and effective. And then understanding this is how all pediatric vaccines that generally start in adulthood come down to pediatrics. There's a relatively small number, and then over time we monitor for those signals. So I guess that's kind of it, that the data was clear, and that there was a very great need for this.
Mm-hmm. And I'll just add that, the data was really compelling presented at the meeting. I would also just say that I wish we had more pediatric data. I feel like we have had such emphasis on really the adult data, and I think there's much more we need to learn about what does long haul COVID look like in children. I think that we are underestimating the potential benefits that go beyond health, to the social emotional benefits of being in school, being able to be present, being able to be part of the community through after-school activities, sports, and what have not. And also just being able to be with family and feeling comfortable and safe. And so I actually really appreciated, Dr. Ball, your comment at the beginning, which is that parents were like crying to be able to give the vaccine to their kids, because I think while sometimes people are focused on the narrative of we only care about severe infection, I personally value the prevention of any infection, and especially for my kids. And I think that we don't talk about that enough. And I love the videos on TV of these kids sitting there getting their shots and just talking all the way through it and just being really excited to be there, because they have an opportunity to feel like, oh, I can go back into the world. That's how I felt when I got vaccinated. And I feel like that's how kids also feel, because they feel that weight of knowing that they're not fully protected against COVID and that not everybody wears masks perfectly all the time. And so giving them that kind of sense of, oh, you have that extra layer of protection now, you're going to be okay. And we're probably going to do other things to continue to protect you until we're making sure that we get to the end of our journey, I hope, which we will get to one day. So that's huge. The other piece that I'll say is, we obviously take safety incredibly seriously as part of ACIP. It's a really important aspect to us to make sure we're weighing that benefit risk balance. Although severe disease is not common, sitting on the hospital side of things, I've personally seen kids severely ill, on ECMO and who have died from infection. I'll also just say that 1/3 of kids who are hospitalized with severe infection, they don't have any risk factors. So it's not always predictable who's going to get sick, which to me, I think is the hardest part. If we knew exactly who was going to get sick, we could target this vaccine perfectly, but we don't always know. And then from the safety perspective, I think, we have to be transparent about what we do know. We have to recognize we've given over 400 million doses in the US, and that, these trials, honestly, the efficacy, they had started out as immunogenicity, but then the efficacy really blew me away again. A 90.7% effective against protecting against infection. To me, that's a meaningful level of protection. And so while we are going to make sure that we're monitoring concerns for myocarditis, I think that what we do know about background rates, to me, was reassuring. We know this is a different dose in younger children. And so all of those things for me kind of added up to, I want to make sure we can provide access to this vaccine for kids in this age group.
Thank you for that. We want to walk through some of the questions that we get a lot from parents in the pediatric offices and at anywhere that's giving the vaccine now. So one of the main ones is, about adverse effects. You mentioned myocarditis, and the biggest question was, were there enough children in that trial, in the 5 to 11-year-old, to be able to assess safety or ensure safety of the vaccine?
Yeah, so I'll just jump in and say that those clinical trials are typically around that size of several thousands to maybe tens of thousands. I think that is like a routine clinical trial. What's probably less typical is the size of the clinical trials that we saw last December. Those 40 to 60,000 people in clinical trials were kind of unprecedented in terms of the amount of data we had for COVID-19 vaccines coming in. So the size of those clinical trials are really to focus on typically, the local and systemic reactogenicity, but also to rule out any frequent serious adverse events. I would say it is pretty unusual for clinical trials to be ruling out incredibly rare risks of like 1 in a million. We could ask for that data, but if you think about like what that means for timing and accessibility, we would be waiting years, honestly, for us to have that information, and missing the opportunity to really protect a huge proportion of the population. I think last December, it was really challenging, and the 40 to 60,000 vaccine sort of population size for those trials was reassuring. But even then, we went into it making sure that we wanted to make sure our safety systems were robust. I hope what you've seen is that we have incredible attention to those safety surveillance systems. And as soon as there's adverse events that are coming through, we are making sure we are transparent and sharing that information with the public. As an example, for the TTS signal following the Janssen vaccine, that was after 6 cases that were reported in the US. So I guarantee people are looking at this on a weekly, if not more often basis. I would say that the trials ruled out any frequent serious adverse events. And we again weigh that into the benefit risk balance about what we know and what we don't know, and recognize that we will continue to monitor closely that safety. I do want to put in a plug for three things. One is for VAERS. I think most pediatricians are aware of this, but I've learned that many of our other subspecialist colleagues actually have never heard of VAERS. So I would encourage you to share that information with your colleagues. And this came up when the myocarditis signal came up, that pediatric cardiologists aren't thinking about VAERS. The second is VSafe, and encouraging parents to report into VSafe for their children, which I think can augment and be a way that individuals can contribute to that safety data. And then the third is for really complex cases, we have a team called CISA that the CDC supports, which is a national group of vaccine safety experts. If you have a very tough clinical case that you would like advice on, they have been available since the start of the pandemic to answer any questions and to actually take consultations from clinicians who want to know what to do next if they're not sure, or if it's causally related. So I would encourage you to use all venues as frequently as possible, because anything that you do to contribute to the safety database, even if you're not sure if it's related, it still adds to our knowledge and it gives us confidence in continuing to support a broad vaccination program.
Thank you so much. So something I probably talk about 10 times a day with families who are deciding whether to give the vaccine is I always hear families worry that there's going to be some sort of long-term side effect to the vaccine and that something bad is going to happen 10 years from now. How do you address that with patients?
So, Dr. Ball, I would say that is not a common finding with vaccines. Vaccines have a method of functioning by stimulating immune response, and we just are not seeing in any vaccine that I can think of side effects or adverse reactions happening years down the line. Or happening acutely and then lasting for years. First thing I think about with that is that's exactly what I think I see with COVID. So that's what I tell parents. I mean, if you're worried about long-term side effects, you need to be worried about COVID, because we have clear data on long-term side effects from COVID.
And I would just say, from the vaccine safety surveillance perspective, I mean, most of the vaccine adverse events we've seen typically occur within 42 days of vaccination. They have, I can say that many vaccine safety surveillance systems have actually specifically tried to look at these longer term side effects and have really not found any associations that in terms of long-term side effects. So I can't think of anything. The only, I want to make sure also people don't confuse the question of long-term side effects with individuals who develop a side effect and then monitoring them. So we are now talking about making sure we have long-term data on in children with myocarditis. But all of those events have happened within the first week of vaccination. So we are tracking and making sure that they continue to have good outcomes. And it's really important for us to do that, again, to make sure that we are continuing to reassure ourselves and our patients and our families that we are doing the right thing. I will also just mention that I strongly feel that ACIP is a decision-making body, but it's really meant to be dynamic in its decision-making. It's not meant to be a one point in time fixed forever and ever. We won't look at the data again. We are always going to continue to look at that data. And if anything changes, we will absolutely reconsider. So I don't want people to feel like we will stop looking. We won't. We're going to continue to look and look under every rock to make sure we can find everything we can. And then I just want to highlight, Dr. Brooks brought up an excellent point. I think the other thing we don't emphasize enough in our communications with families is the safety of vaccines. We're always, I sometimes make this mistake of focusing on what I do know, but I don't do enough of what Dr. Brooks just did, which is to say, but gosh, look at the risks of COVID-19 infection. And we know that those are so severe. And honestly, I feel like we don't put that into context, the safety into the context of the overall pandemic or for the overall benefits of vaccination. And I think the more that we can continue to do that when we talk about safety, the better off we are.
I'm going to break in for 1 second, just piggyback on that, Dr. Lee. Someone asked in the chat box, what data do we have on long COVID and these kind of long-term effects of COVID? I know we have more evidence in adults. We know we're seeing it in kids, but do we have any good evidence about it?
You mean in children?
Yes, in children. So sorry, children.
No.
Well, I can say, so I'm actually part of, I'm very fortunate to be a part of another group, which is the NIH initiative to look at long haul COVID. And there are specifically pediatric cohorts that are being followed clinically. And we are at Stanford contributing to an EHR based, real world data cohort. And there's two things I'll say. One is it does happen. We don't understand quite, I feel like we've seen prevalence estimates in kids that really vary. It probably may not occur as often as it does in adults. However, I will say that I think that we are not as good at identifying it in children because by definition, PASC is a change from baseline, post-acute sequelae of COVID or long haul COVID. PASC is a change from baseline. And so adults are very well able to articulate that I don't feel the same way I did before I got COVID. Kids may not be able to articulate that. Plus, kids are constantly changing. Kids are constantly moving in terms of the developmental milestones. So we might think that they're progressing along, but in fact, their trajectory has been altered by COVID infection in ways that we can't yet understand. So I do think that we have underestimated perhaps the burden in ways that it's been much easier to estimate in adults. And then the last thing I'll say is we are now investigating whether or not the phenotype of COVID looks the same in kids as it does in adults. It may look similar in some cases. It may look different in other cases. And I think we have a lot more work to do in that area.
So sometimes we have a really large 11-year-old or a really small 12-year-old. Can you talk about the dosing? Do we give them a larger dose or the older dose if they're overweight, young child, or vice versa? Tell us a little bit about that.
In the studies, the children 5 to 11, their first dose, let's say 11, in the studies, they both got 0.2 or 10 micrograms. I think the tricky thing to me, my feeling is, and it's interesting because this was never discussed. I'm not convinced that it's due to body weight as much as it may be due to immunogenicity. Children tend to have a strong immunologic reaction. So, and if the 1/3 dose worked in children, I'm not exactly sure it's because their bodies are smaller, but it was done. Okay. So the challenge is if you give a child in 11 months to 0.2, and then they turn 12, and they'll say they're a big, 12-year-old, a lot of pediatricians' offices aren't going to have the 0.3 anyway, because the 0.3 still has the same storage requirements. So I know at our health center, we're going to have 0.2. So what'll happen, at least in my health center, my department of pediatrics, is the children will get 0.2 twice, 3 weeks apart or so.
That's interesting. Yeah. So, and I think there's flexibility written into the EUA and the ACIP recommendation language. I think, and I'm coming at it from a different perspective. So I don't have to manage an office supply. It's, at the hospital, so it's a little easier for me, to be honest, than it is, I think, in a primary care office, where I think you're not only managing the complexity of the supply, but also the financial burden of the supply. And I recognize even though COVID vaccines are free, it still is a burden. So the way I've been thinking about this, and you're right, we didn't talk about it in detail, is from an implementation perspective, age-based vaccination is just sort of a more straightforward way to go. And I'm thinking of pharmacies or large sort of drive-throughs where it would just be, if you're 5 to 11, you get the 10 microgram dose or the 0.2, as Dr. Brooks was saying. And if you're 12 and older, just get the 30 microgram dose. And if you look at the clinical considerations page, which is up, I actually think it's really useful. I'm not going to read through it, but I will say that it is extremely helpful for thinking through the various scenarios where there might have been an administration error. And for the most part, the recommendation for kids is not to redose if you were younger and you got a 30 microgram dose, or if you're older and you got a 10 microgram dose. We don't want that to happen, but I think that if that happens, we're not going to suggest you redose a younger kid. The other thing is as you know, there's the age-based component, and as Dr. Brooks mentioned, we don't believe that there is a weight-based component. However, for what it's worth, in the clinical trial that was done by Pfizer, for kids who were 11 during dose 1 but turned 12 during their dose 2, they actually had given the 10 microgram dose for both dose 1 and dose 2. So I think the answer, and that still was efficacious. So I think and probably because they were on the younger side and responded extremely well to the vaccine. So the answer to me is make a rule that's simple, that's easy to follow to minimize errors. And then if you do, take a look at clinical considerations, but probably it's going to be okay. And I think the main thing is we just want to make sure we're making sure we can protect kids and minimize the side effects. And those are the only two things we can do for them.
So with the exception of safety concerns, the main reason I hear for people not getting vaccinated, both for their children and for themselves, is they tell me that they've already had COVID and that they have natural immunity, which is a term I'm not really thrilled about. So 2 questions related to that. One is, what do you think about that? And do children who have had a documented case of SARS-CoV-2 actually need to get vaccinated? And if you do think they do you think they can get by with only 1 dose, or do you think they should do the full 2-dose regimen?
No, that's tricky. First, the simple answer is yes. Yes, they should do the. Take that one, Grace.
Oh, sorry. So in terms of, sorry, part 1 of your question again.
So if they've already had COVID in the past, a lot of parents say they don't want to vaccinate.
Yeah, so I just had a disruption. First of all, in the studies, 40% of the kids were seropositive. Excuse me, 40% of the population is seropositive. In studies, I think it was 7% were seropositive. So we are seeing, of course, that there are children that have circulating antibodies, but the immunity is waning. So the other thing is with COVID-19 in general, natural, as you say, immunity is not as strong as we see in a lot of other viral conditions. I mean, children that got chickenpox are, generally immune. If you actually had measles as a child, you're immune for life. But it's not like that with this virus. So I would say that those parents, yes, your child needs to get immunized. We don't test for it. That was in the study. And they would need the standard 5 to 11, they need 2 doses.
Yeah, I agree. And what I was most struck by the Pfizer data that was presented at our ACIP meeting, where if you looked at the neutralizing antibody titers of the kids who were previously infected, what they showed was actually those previously infected kids had very low titers. And actually, if those were adults we were seeing, we would be giving them a booster because we would say those are probably too low for protection. So to me, I looked at that and I was like, oh, I really think probably I would absolutely recommend kids get vaccinated, even with a known history of prior infection, looking at their neutralizing antibody titers coming into the trial. The second thing I'll say is that a large number of kids do have asymptomatic infection. And what we've noticed is that the more severe your disease, the higher your antibody titers are. And if you are asymptomatic, probably the lower your antibody titer. So my guess is that they're probably not as protected, and they are absolutely going to benefit from the vaccine. When they got the 2 doses, they got to fairly high antibody titers that were clearly protective. You asked the question, sorry, I remember now part 2, about 1 dose versus 2 dose. And right now the trials are with 2 doses. I think I would be worried about just giving 1 dose and assuming that child is protected, because I just was impressed with how low those neutralizing antibody titers were, even in previously infected kids. So I'd want my child to get 2 doses.
And Dr. Ball, let me add one quick thing. When in doubt, I go by what the clinical trials did. So I think that when you're questioning, start saying, oh, I'm going to give 1. Oh, I'm going to wait 6 months instead of 3 weeks. No, go with the clinical trials. That's where the data came from. So that's something I would also say to those who are, intimately involved in making these decisions.
Some families have asked if they should wait for the Moderna vaccine to be approved for this age group. What would your answer be to that? And do you know when the Moderna clinical trials are expected to finish and when that vaccine might be approved?
I'm sure Grace knows when they are going to be finished. I'm not exactly sure, but the simple answer is no, I wouldn't wait, because there's a concept in pediatrics that was shared with me that is called delay. So if you get your DPT, your primary series at 3, 5, and 7 months, that's 3 months of delay that you've been exposed. So I see no reason to wait. And as far as I'm concerned, I'm skeptical enough to say that we don't even know Moderna is going to be approved. I don't make a decision until I see all the data and have it all in front of me and have it dissected by the safety committee and then by the work group of which I sit on. And then when the whole committee comes together, they all see it differently maybe than I saw it on the work group. So I clearly would not wait, just for that simple reason, a couple of reasons that I just gave you.
Yeah, I don't like to miss opportunities to vaccinate. And I would just say with like Thanksgiving and Christmas coming, I know a lot of people are going to be seeing elderly family members. And to me, I just think it seems like a good idea to try and protect your kids and to actually protect your family.
So speaking of that, for every family I've seen who's been overjoyed that their 5 to 11-year-old is going to be vaccinated, I've had another family who's dismayed because their 3 or 4-year-old cannot be vaccinated. I'm wondering if you have any insight into when we might see vaccines for those age groups.
I'm trying to think of what's publicly available. That is definitely coming next. And I think, we hope that there will be data at some point in the coming months. But I don't anticipate we're going to be meeting for at least another month, Dr. Brooks. So I think we're still at the beginning. Oh no, maybe another month and a half. I don't know. We'll see how it goes. But our next hopeful meeting will be in January at some point, and we'll see how things go. We still have some catch up we're doing, which is why we're meeting in January. But if there's a fortuitous, event where we can also look at that, I think that'd be great. We're all looking forward to it.
How do you recommend talking to families who might be reluctant or hesitant to give their younger child the COVID vaccine?
So first of all, every family has a slightly different reason for being hesitant. So make no assumption. Listen to exactly what they're concerned about. I don't think it's going to be too different than what people were concerned about in terms of the adult age. It's going to just be extrapolated down to a younger age. So what I always stick with is it's safe and effective. I say that I have no vested interest in making this recommendation. I don't get paid to get you vaccinated, and that I have studied all the evidence and weighed it appropriately and feel that I am more worried about COVID than any problems with the vaccine. But if their concern is it was developed too fast, and you let them know that there are particular reasons for the government paid for the vaccine to be manufactured before it was even approved, so they could have thrown it out and not lost any money if it didn't get approved. That these things that, well, I don't know, they worry about infertility and microchips for the children. I don't know. Maybe for your teenage girls, you hope it has some level of infertility in it because you don't want your teenage girl pregnant. But I just ask them exactly what it is they're worried about, and generally with what I've studied and what I know, I can refute that. But understand it's coming from the heart pretty much more so than the brain. That's the other thing that I always say.
I guess for me, it's really, and I agree 100% that two things. One is, although these are the kinds of conversations we need to have, in many ways, in pediatricians' offices and family practitioners' offices, we're pressured to get people through in like a very short period of time. And people want to have this deep and meaningful conversation about their values and understanding like what it is, what information they need, and what do they really value in their lives. I feel like, number one, I think that is the way forward, is to have that conversation and to be open to it and to really consider a shared decision-making framework and giving people the information they need. I do believe that if we understand where they're coming from and what their concerns are, we can get there. But second, I'll just say, like, I think that, I just wish that our health system was different, and that these conversations around prevention were really valued by the health system in a different way, because I feel like they're so impactful, and yet, we're still very procedurally oriented despite our interest in getting to a value-based system.
And one thing I'm going to add to what she says, I generally feel if someone is truly hesitant, I don't give them any more than about 2 minutes. And that's a lot. Because if you can't make your point in about 2 minutes, you're not going to make it. So that time restraint is there, but it's also practically speaking, a lot of people you're just not going to convince them. But you always leave
more
it
efficient than me then.
We appreciate that. Thanks for those tips. There's a lot of questions in the chat box about contraindications and allergies. So particularly if there are kids with severe food allergies, do you need to avoid the vaccine? Do you need to do anything different? What are contraindications to this vaccination?
I'll say that I know of very few polyethylene glycol. Food allergies, no. If someone's really worried their cat had anaphylaxis from peanuts, the answer is still no. But I would say if you have that concern, then speak to your allergist. But minimal in terms of contraindications. I mean, I can think of the one that I mentioned. They say things like prior adverse reaction to a prior dose. It's like usually written in there. For most of these kids, it's going to be their first dose.
Yeah, and I would say, like, unless you've had an allergic reaction to this particular vaccine, it's pretty much, and like by allergic reaction, I mean anaphylaxis. Really, that's really the only true contraindication. And we've actually, and I know many of our colleagues have had worked with our allergy colleagues, because when they first came out, we were, telling people, of course, who had a history of allergies to bring their EpiPens with them to the visit, because that's always the safest thing to do. And they should have their EpiPens with them anyway, period. So bring that to the visit and make sure you have a longer watch period for them. But the typical watch period is 15 minutes post-vaccination, 30 minutes if you have this history. But really the only contraindication is a prior anaphylactic event to this particular vaccine. So I typically only see it after dose 1. There have also been studies that have shown that the PEG component isn't as concerning, that people can be safely vaccinated even despite having had an allergic event with dose 1. I do usually rely on my allergy colleagues to make sure that I'm giving the best possible guidance. But otherwise, I would say there really are no contraindications other than anaphylaxis to a prior mRNA dose or J&J dose.
Thank you for clarifying that. So outside of your role at ACIP and more of as a California healthcare provider, how do you think schools should approach their recommendation towards COVID vaccination?
Yeah, that's a tough one. I think that we'll have more information over time. I think that mandating the vaccine at this point, I'm just not sure. I know the LAUSD has one of the school districts in Los Angeles, for example, there are some considerations there is for the 12 to 15 years of age. I think that the school should encourage vaccination and make access to the vaccine or getting vaccinated a priority. And we just know that the more children that are vaccinated, the less disruption there will be in school. As I said, as it relates to mandates, there may be some coming. I think that we need more data before we can do anything like that.
Yeah, and I'll just clarify that Governor Newsom put out an announcement that the that CDPH they're going to take under consideration the recommendations of ACIP and AAP and AAFP regarding a potential school requirement similar to many other vaccine requirements we have for schools. To be clear, it is only under full licensure, and I anticipate that that California and the Western states has a scientific safety review committee that actually Dr. Brooks and I also sit on together, and we are also reviewing that data to make sure that we are providing the best guidance specifically for California residents. Advising the CDPH on use of vaccines in California. So I would say under an EUA, in my mind, the answer is no. So that 5 to 11-year-old, we're under an EUA right now. I think where we're under a full licensure, so a BLA, as Pfizer for the older population has been done, then that is something that they are willing to consider. And I think, I think, to be honest, we struggled, all of us as healthcare institutions and providers, with the healthcare mandate. And it was a really tough set of conversations to have. But I will say that, like, our institutions are 98% vaccinated. And it's just like incredible how helpful it has been to make sure that our staff and providers are protected, and that we are protecting the patients that we care for that are medically vulnerable. And I think that's been so important for us. I am hopeful that we will feel very confident about being able to implement this in schools. In the meantime, we want to make sure we're providing access. And I think access right now and building confidence in the vaccination program is going to be critical.
And to underscore, she said that is exactly the data that I'm referencing, BLA, because when we have BLA, there's more time. We could be looking at some other safety signals that may occur. So yes.
So we now have an approved vaccination for children 5 and older, which encompasses almost all of the children who are in our school systems. Do you, using your crystal ball, what do you feel is going to happen with masks as we vaccinate more and more school-age children?
Well, okay. Oh boy, you want to ask the easy questions tonight. So I would say, like, my perspective on masks is it is very much tied to community transmission. So we have to understand where we are in our local communities in terms of what's going on. And that data is going to be critical to driving, in general, the use of masks. I'll also just say, like, I do believe that, masks are helpful in protecting those who are not vaccinated, either because they're not eligible or because they don't respond to vaccines. It's really important to remember that we have a lot of people who, might be working or children who want to attend school who are moderately to severely immunocompromised, and they might not have an optimal response. I feel like if I can do my part and, as a student or as a teacher, and be able to create a safe environment for everyone, regardless of whether they can respond to the vaccine or are eligible to the vaccine, to me, that's a really important thing for us to do. I recognize not everybody feels the same way, but I maybe it's a healthcare provider in me.
I go along with that, seriously.
All right, well, as we're nearing the end of the hour, I'd like to hear how you think this all ends, if it ever does. Where do we go from here, and what is the end in sight?
Well, as Yogi Berra said, the hardest thing to predict is the future. So my crystal ball is a little cloudy nowadays. But what I really believe, I think it's going to end. I think that if we get to a certain percentage of the population that is vaccinated, I believe that we will have what I call a smoldering epidemic. They will be circulating coronavirus, SARS-CoV-2, but the amount that circulates will be lower because people are more fully vaccinated. The more fully vaccinated the population, the less likely to develop these variants of concern. I think that a lot of people think, that we may end up with a yearly vaccine. I'm not really sure. I think we have to understand that this is a novel virus that's been since about only less than 2 years since it's been in the United States at a pandemic level. I believe that we will continue to have those that are vaccine hesitant, but I think that number may drop as times pass. And people, I want to see what happens in a year. Okay, it's been a year and nothing happened. So I think that more and more people will get vaccinated, but there's going to be a baseline somewhere around probably 10% or somewhere between like 8 and 12% that are not going to be vaccinated, and those will be the ones of concern to me.
Yeah, and I think that I agree 100% that if we can get a greater proportion of the population vaccinated, the better protected we all are. I'll also just say, it's important for us to remember that there are, therapies which I think are underused in certain populations, such as monoclonal antibody therapy. And part of it has been the challenge with, access and timeliness and early diagnosis and referral. I am hopeful there will be better meds that we can use on an outpatient basis as well at some point. With vaccines, better therapies, prevention, better management, better treatment options. And, you know, I still think we're going to have to rely on masks until we can get to that point where we are even. I will say though, like the one thing I like about masks is that we haven't seen any respiratory viral infections in our hospital workers basically since the pandemic started. And that's because we've been wearing these masks. Whereas we always have little blips of RSV in the hospital or flu or whatever else is going on, either because, you know, kids are coming in with it, staff are minimally symptomatic or don't notice that they're sick, or, you know, parents and families who are visiting are also coming in with it. So like, I've been enjoying the low rate of respiratory viral infections personally, but but I recognize it will come to an end one day. And I hope that when it does, that at least what we can do is keep people out of the hospital being severely ill or dying from COVID, because every death that we have in kids and adults, to me, is a potentially preventable death. And we want to make sure we can achieve that. This is now the 8th leading cause of death in the US for kids 5 to 11, which to me is just alarming. I know people think that it's not severe, but again, if we don't have to live through it, I'm not sure why we are wanting to.
Dr. Brooks, Dr. Lee, thank you so much for your time tonight. This was really fantastic. As we mentioned, this was our 9th COVID conversation. Our first one was December 9th, 2020. That was a week before the COVID vaccine started going into arms in adults, 8 days before I received my first COVID vaccine. And a year later, we're finally vaccinating children. So it's really fantastic. So thank you for joining us and for all of your work. After the webinar is over, everyone, an evaluation will pop up on the screen. It's really valuable to us because it allows us to get topics for future COVID conversations. Next. Oh, as you guys probably know, they're still taking applications for CalVax grants at the state. So if you're providing COVID vaccines in your office, you can get paid for that, which is really cool. Next. So we are going to take the month of December off because we are all really tired and we got vaccinating to do now. Hey, that's me. And so we're going to spend December vaccinating our kids. We'll be back in January with whatever hot topic comes then. It sounds like it might be vaccinating the 2 to 5-year-olds. We shall see. You can find a recording of this on our YouTube channel, as well as the California Immunization Coalition's website at immunizeca.org. And again, thank you all for joining us, and thanks for all you do for the community and for kids.
Thank you so much.
All right. Thank you.
Yeah.